This is how vision problems often start after 60, not with something you notice, not with something that hurts, with something that happens in the dark, in the 8 hours when your eyes are closed, when you are not aware of what is occurring on their surface, in their internal pressure, in the tissue that your vision depends on for renewal. What happens to your eyes during the night, specifically during those 8 hours, is determined almost entirely by habits you form before and during sleep that most adults over 60 have never connected to their eyes at all. And what doctors are seeing in the clinical patterns of visual decline in their patients over 60 is a remarkably consistent relationship between specific nightly habits and specific early-stage eye changes. Changes that, if caught early enough and the habits that cause them addressed promptly enough, can be slowed or stopped. Changes that, if not caught and not addressed, progress silently toward the visual impairment that eventually becomes impossible to miss. Tonight, in 8 hours, one of those two stories will play out for your eyes. Let me tell you which habits determine which story. The 8 hours of sleep are the longest single period in any 24-hour cycle during which your eyes receive no conscious attention. You are not blinking deliberately. You are not applying drops. You are not adjusting lighting. You are not aware of any discomfort until you wake. And by then, whatever has been happening on the ocular surface and in the intraocular environment has already been happening for hours. For adults over 60, those 8 unmonitored hours carry specific risks that accumulate differently from in younger eyes, because 3 fundamental changes in ocular physiology after 60 make the nighttime environment increasingly demanding for the aging eye. Change 1. Reduced tear production. After 60, the lacrimal glands, the primary tear-producing structures above each eye, produce less tear volume than in younger years. This reduction is driven by age-related atrophy of lacrimal acinar cells and by the declining hormonal signaling, particularly reduced androgen and estrogen levels, that supports lacrimal gland secretory function. Research has documented that tear production rates in adults over 65 are significantly lower than in younger adults, and that this reduction is more pronounced during sleep when lacrimal gland activity is at its daily minimum. Simultaneously, meibomian gland function, the oil-secreting glands in the eyelids that produce the lipid layer preventing overnight tear evaporation, declines progressively after 60. Research using meibography, direct imaging of meibomian gland structure, has documented that adults over 60 show significant meibomian gland dropout, irreversible loss of gland tissue, at rates substantially higher than in younger adults. The combination of reduced aqueous tear production and reduced meibomian lipid secretion produces a tear film that is too thin, too unstable, and too prone to evaporation to adequately protect the corneal surface through 8 hours of sleep. Change 2. Declining optic nerve pressure tolerance. After 60, the lamina cribrosa, the sieve-like structure at the optic nerve head through which the retinal ganglion cell axons pass as they exit the eye, becomes stiffer and less compliant with age. This reduced compliance means that the same intraocular pressure that was well tolerated at 40 exerts greater mechanical stress on the optic nerve fibers at 65. And since intraocular pressure is highest during the horizontal sleep period, elevated by the postural and circadian factors already described, The 8 hours of sleep represent the 8 hours of greatest mechanical stress on an optic nerve that is simultaneously less tolerant of that stress. Change 3. Impaired retinal repair efficiency. The retinal pigment epithelium cells responsible for nightly photoreceptor renewal become less phagocytically efficient after 60, accumulating lipofuscin, reducing their lysosomal digestion capacity, and performing the overnight outer segment recycling cycle more slowly and less completely than in younger eyes. Every habit that further impairs the conditions for this cycle, elevated blood glucose, disrupted sleep architecture, melatonin suppression from light exposure, compounds the already reduced efficiency of the aging RPE. The National Eye Institute identifies the combination of RPE dysfunction, reduced choroidal blood flow, and drusen accumulation, all of which are accelerated by specific nightly habits, as the preclinical pattern that precedes clinical age-related macular degeneration by years. Understanding these three changes, reduced tear protection, declining pressure tolerance, and impaired retinal repair, provides the framework for understanding why specific nightly habits that were harmless in younger years produce measurable harm after 60. Today I am going to walk you through 5 nightly habits that interact specifically with these 3 age-related vulnerabilities, and the 5 protective changes that directly address each of them. Drop your age in the comments and tell me, what does your eye health feel like in the morning? Gritty? Blurred for the first few minutes? Dry? Slow to clear? These morning symptoms are the direct readout of what happened to your eyes during the night, and they are telling you something worth understanding. Habit number 1, running the heating or air conditioning. All night with dry indoor air. Sleep with central heating, maintaining a warm bedroom temperature through the winter. Sleep with air conditioning providing cool air through the summer. Both systems run continuously through the night, and both produce the same specific problem for the aging ocular surface. What it is doing to aging eyes, both heating and air conditioning reduce indoor relative humidity, the water vapor content of the bedroom air. Heating does this by warming air without adding moisture. Since warm air holds more water vapor, the relative humidity of heated air falls unless moisture is actively added. Air conditioning does this by a dehumidification mechanism that is inherent to the refrigerant cycle cooling process. Research has documented that indoor relative humidity during sleep in heated or air-conditioned bedrooms commonly falls below 30%, significantly below the 40 to 60% range that supports tear film stability. At low ambient humidity, the rate of transevaporative tear film loss from the ocular surface increases dramatically, producing a nightly desiccation of the corneal surface that is most severe in the hours immediately before waking, when tear production is lowest and the accumulated evaporative loss is greatest. For adults over 60, whose baseline tear production is already reduced and whose meibomian lipid layer is already inadequate, sleeping in a low humidity, heated, or air-conditioned environment produces a degree of overnight corneal desiccation that progressively damages the corneal epithelium. The morning symptoms of this damage are familiar to most adults over 60. The gritty, uncomfortable awakening. The blurred vision that takes minutes to clear as the blink reflex redistributes the limited tears available. The eyelids that feel stuck to the corneal surface upon first opening. These are not simply the effects of sleep. They are the symptoms of overnight corneal desiccation in an environment that the aging tear film cannot adequately compensate for. Over years, chronic corneal surface damage from nightly desiccation produces the corneal irregularity, the microscopic disruption of the epithelial surface that scatters light, responsible for a significant proportion of the visual blur and glare sensitivity that adults over 60 attribute to other causes. Add a cool mist humidifier to the bedroom, positioned to maintain relative humidity between 45 and 55%. A hygrometer, an inexpensive instrument that measures relative humidity, placed in the bedroom tells you immediately whether your sleeping environment is within the range that supports tear film stability. Target 50% relative humidity as your sleeping environment standard. This single environmental change can dramatically reduce the overnight ocular surface desiccation that the aging tear film cannot compensate for on its own. Habit number 2, sleeping with a fan directed at the face. Use a bedside or ceiling fan for cooling during warmer months, with the airflow directed across the face and body during sleep. This is so common and so apparently harmless that most adults have never considered it as having any bearing on their eye health. What it is doing to aging eyes. A fan directed at the face during sleep produces convective evaporation of the tear film. The movement of air across the ocular surface dramatically accelerates tear evaporation rate compared to still air. Research has documented that even mild air movement, the gentle airflow of a tabletop fan, increases tear evaporation rate by a factor of 2 to 3 compared to still indoor air at the same temperature and humidity. For adults over 60 with reduced basal tear secretion and inadequate meibomian lipid layer, convective evaporation from fan airflow during 8 hours of closed-eye sleep produces accelerated corneal desiccation beyond what the dry air effect of heating and air conditioning alone produces. The combination of low indoor humidity and directed airflow creates the most desiccating overnight ocular environment available in a typical bedroom, and the aging tear film is the least capable of compensating for it. Additionally, fan airflow during sleep delivers airborne allergens, dust particles, and microorganisms to the facial region, including to the ocular surface through the incomplete seal of closed eyelids in deep sleep. For adults with pre-existing ocular surface inflammation, which is the case for many older adults with chronic dry eye and meibomian gland dysfunction, this allergen delivery compounds the inflammatory burden on an already compromised ocular surface. Redirect fan airflow away from the face and head toward the feet or across the room rather than directly at the sleeping position. If facial cooling is necessary for sleep comfort, use a lower fan speed, position the fan further from the bed, and consider using a humidifier alongside the fan to compensate for the additional evaporative load. Alternatively, use a bedside fan directed sideways across the body at waist level, which provides cooling air movement without directing the airflow across the facial ocular surface. Habit number 3, failing to remove contact lenses before sleep. Most contact lens wearers remove their lenses before sleep, but a significant proportion of adults over 60 who wear occasional or part-time contact lenses fall asleep with them still in, particularly on evenings when they are tired, when they have fallen asleep watching television, or when they simply forget. And some adults wear extended wear lenses under the impression that they are approved for overnight use and therefore safe. What it is doing to aging eyes. Contact lenses. including those approved for extended wear, significantly reduce the oxygen availability to the cornea during sleep. The closed eye sleeping state already reduces corneal oxygen supply because the eyelid blocks atmospheric oxygen. Contact lenses add a second barrier to oxygen diffusion and simultaneously reduce the tear circulation beneath the lens that is the cornea's primary nutrient delivery mechanism when the eye is closed. For younger corneas with robust epithelial cell replacement capacity, overnight contact lens wear produces manageable oxygen stress. After 60, when corneal epithelial cell renewal is slower, when the epithelium is thinner, and when the tear film that lubricates the lens-cornea interface is already reduced, overnight contact lens wear produces corneal hypoxia that causes epithelial erosions, stromal swelling, and the neovascularization, abnormal blood vessel growth into the cornea. That is one of the serious complications of chronic corneal oxygen deprivation. Additionally, the bacterial biofilm that accumulates on contact lens surfaces during wearing hours poses a significant infection risk if retained during sleep. Microbial keratitis, corneal infection, is the most serious acute complication of contact lens wear, and its risk increases dramatically with overnight lens retention. In adults over 60 whose corneal immune defenses are less robust than in younger adults, the consequences of a contact lens-related corneal infection are more severe and more likely to result in permanent visual impairment. Remove contact lenses every night without exception, regardless of tiredness, regardless of lens type, regardless of approved wear schedule. If you use extended wear lenses and have been told they are safe for overnight use, ask your eye care professional specifically whether this recommendation applies to an adult of your age with your specific corneal and tear film health status. For adults over 60 with any degree of dry eye, which describes the majority, extended wear contact lens use is considerably more risky than in younger patients with healthy tear films, and the overnight removal habit is correspondingly more important. Habit number 4, taking antihistamines or decongestants as sleep aids. Many adults over 60 who struggle with sleep onset, or who have seasonal allergy symptoms that disrupt sleep, use over-the-counter antihistamines as sleep aids. Diphenhydramine, the active ingredient in many sleep aid products including Nitol and Benadryl, is one of the most commonly self-administered medications in this age group. It is available without prescription, seems safe, and produces the drowsiness that makes it feel effective as a sleep promoter. What it is doing to aging eyes. Antihistamines are anticholinergic medications. They block the muscarinic acetylcholine receptors that mediate secretory gland activity throughout the body. The lacrimal glands that produce tears are heavily dependent on cholinergic signaling for their secretory activity. When antihistamines block cholinergic receptors in the lacrimal glands, which they do, dose-dependently, tear production falls significantly for the duration of the drug's activity, which for diphenhydramine, with a half-life of 6 to 12 hours, means throughout the entire sleep period. For adults over 60 whose baseline tear production is already reduced, consuming an anticholinergic medication that further suppresses lacrimal gland secretion throughout the 8-hour sleep period produces the most severe overnight ocular surface desiccation available from a commonly used medication. The nightly use of antihistamine sleep aids in this age group is a significant and largely unrecognized contributor to the progressive dry eye disease that affects the majority of adults over 65. Additionally, anticholinergic medications, including antihistamines, have a documented effect on intraocular pressure through a separate mechanism. In susceptible individuals, particularly those with narrow-angle anatomy, anticholinergic drugs can precipitate acute angle closure glaucoma by producing pupil dilation that mechanically closes the drainage angle. While frank angle closure glaucoma from antihistamine use is uncommon, the mydriatic, pupil dilating effect of these drugs during sleep increases the risk of elevated intraocular pressure in adults with predisposing anatomy. The American Academy of Ophthalmology specifically identifies anticholinergic medications as a cause of both dry eye disease and potentially elevated intraocular pressure, and lists antihistamines among the medication classes of greatest concern for older adults with pre-existing ocular surface disease or glaucoma risk. Discuss antihistamine sleep aid use with your physician, particularly if you have dry eye disease, glaucoma, or elevated intraocular pressure. Alternative sleep approaches, sleep hygiene optimization, melatonin supplementation, cognitive behavioral therapy for insomnia, do not carry the ocular side effects of anticholinergic medication. If antihistamine use is unavoidable, apply generous amounts of preservative-free lubricating gel to both eyes before sleep on nights when antihistamines are taken to partially compensate for the lacrimal gland suppression they produce. Habit number 5. Sleeping inconsistently. Irregular sleep and wake times. Sleep at inconsistent times. Different bedtime every night depending on television schedules, social plans, tiredness levels, and general routine. Wake at different times on weekdays and weekends. Nap during the day to compensate for poor nighttime sleep. In retirement, when the external structure of employment schedules is removed, this sleep time and inconsistency becomes particularly common. What it is doing to aging eyes. The nightly retinal repair cycle, photoreceptor outer segment renewal, RPE phagocytosis, choroidal blood flow optimization, is circadian timed. It is not simply a response to darkness or to the onset of sleep, wherever in the 24-hour cycle that occurs. It is a biological program timed by the circadian clock to occur at a specific phase of the daily light-dark cycle, typically the early hours of darkness following the evening light period. When sleep timing is irregular, when the transition to darkness and sleep occurs at different times on different nights, the circadian timing of the retinal repair cycle is disrupted. The RPE phagocytosis peak, timed to the expected darkness onset, may precede or follow the actual sleep onset, producing a misalignment between the body's circadian repair program and the actual sleep period during which the eye is closed and able to benefit from it. Research on circadian misalignment, the disruption of biological clock timing by irregular sleep schedules, has documented measurable effects on multiple aspects of retinal physiology, including RPE function, choroidal blood flow regulation, and the nightly intraocular pressure reduction that depends on the circadian timing of the autonomic nervous system shift. Adults with consistently irregular sleep schedules show significantly worse metrics on multiple retinal health indicators than those with consistent, well-timed sleep, even when total sleep duration is equivalent. For adults over 60, in whom the retinal repair cycle is already operating with reduced efficiency due to age-related RPE changes, circadian misalignment from irregular sleep timing adds an additional layer of impairment to an already compromised maintenance process. The National Eye Institute has acknowledged circadian clock function as a critical regulator of retinal homeostasis. noting that age-related changes in circadian amplitude and precision are themselves contributors to the declining retinal repair efficiency that precedes age-related macular degeneration. Establish and maintain consistent sleep and wake times, 7 days a week, regardless of weekend social plans or daytime napping temptation. This is the most important single habit for maintaining the circadian timing that supports efficient nightly retinal repair. A practical approach. Choose a fixed wake time and maintain it every day, including weekends and holidays. The consistent wake time anchors the circadian clock far more effectively than a fixed bedtime because the morning light exposure following a consistent wake time provides the strongest available circadian reset signal. Bedtime then self-adjusts based on accumulated sleep drive, and within 2 to 3 weeks of consistent wake time anchoring, the entire sleep-wake cycle stabilizes into a regular pattern that supports the circadian timing of nightly retinal repair. The 5 protective changes. Change. 1. Add a cool mist humidifier to the bedroom. Target 45 to 55% relative humidity. This single environmental change reduces the overnight corneal desiccation that the aging tear film cannot compensate for in a typical heated or air-conditioned bedroom. Change 2. Redirect fan airflow away from the face during sleep. Convective evaporation from fan airflow accelerates tear film loss at a rate the aging tear film cannot sustain for 8 hours. Foot-level or room-level fan positioning provides cooling without corneal desiccation. Change 3. Remove contact lenses every night without exception. No contact lens, regardless of approved extended wear schedule, is safe for routine overnight use in adults over 60 with reduced tear production and impaired corneal repair capacity. Change 4. Replace antihistamine sleep aids with ocular surface-safe alternatives. Melatonin supplementation, 0.5 to 1 milligram taken 30 to 60 minutes before your target sleep time, provides sleep onset support without anticholinergic lacrimal gland suppression. Discuss alternatives with your physician. Change 5. Establish a fixed daily wake time and maintain it 7 days a week. Circadian consistency supports the timing of the nightly retinal repair cycle more effectively than any other sleep habit change, and it is completely free. The 8 hours of sleep are the 8 hours that determine whether your aging eyes arrive at each morning better or worse than the night before. Whether the photoreceptors that gave you today's vision are renewed and ready for tomorrow's. Whether the corneal surface that transmits all of that vision is intact and smooth or eroded and irregular. Whether the optic nerve fibers that carry every visual signal you have ever experienced are navigating the night under manageable pressure or under pressure that is quietly, progressively exceeding their tolerance. These are not abstract concerns. They are the biological realities of the aging eye, realities that determine the trajectory of your vision over the next decade in ways that depend far more on nightly habits than most adults have ever been told. The 5 nightly habits I described today, dry heated air, face-directed fans, overnight contact lenses, antihistamine sleep aids, and irregular sleep timing, are the habits most consistently associated in the clinical patterns doctors observe with the early-stage eye changes that precede the visual decline most adults over 60 fear most. And the 5 protective changes are simple, affordable, immediately implementable: a humidifier, a redirected fan, a contact lens removal habit, a conversation with your physician about your sleep aids, a fixed daily wake time. These are the changes that give your eyes the 8 hours they need. Leave your age and your morning eye symptoms in the comments. Gritty, blurred, slow to clear, stuck eyelids. Those symptoms are telling you something about what happened during the night.